Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. For high-risk prenatal care, we're going to start by looking at Justine. Justine is a 38-year-old female who's 36 weeks pregnant that arrives to labor and delivery with a headache that won't go away with Tylenol. She also says, I keep seeing floaters and I've even been throwing up. I have some swelling and my upper abdomen is really hurting and my head hurts so bad. If you have a patient that comes in with these types of complaints, what might you think is happening with her? I would be concerned that perhaps she has hypertension or preeclampsia, and a good way to know this first and foremost is to take her blood pressure. There's a lot of things that can cause headaches and nausea and feelings like this in pregnancy, but a blood pressure is going to give us a good indicator. So we put a blood pressure cuff on Justine, and we find that her blood pressure is 156/98. So it's elevated. So let's think about hypertension and preeclampsia. If you have a blood pressure greater than 140 systolic or greater than 90 millimeters of mercury diastolic, and this is based on two separate measurements at least 4 hours apart, this is hypertension. If you have blood pressures greater than 160 systolic or greater than 110 diastolic based on two separate measurements more than 4 hours apart, this is considered severe hypertension. If your patient develops hypertension after 20 weeks of gestation and has been normotensive prior to that, this is a gestational condition caused by the pregnancy, and this is called gestational hypertension. But if she has high blood pressure prior to becoming pregnant, or if it appears prior to 20 weeks gestation, this is considered a chronic condition or chronic hypertension. So when we think about preeclampsia, how we diagnose it, first we're going to have high blood pressures greater than 140/90, at least two, more than 4 hours apart, but then we're going to have at least one other symptom related to the organ systems that are involved. So preeclampsia can affect multiple organ systems. So other things we might see, proteinuria, elevated liver function tests, edema, including like in the face, renal insufficiency or oliguria, thrombocytopenia, visual changes like blurry visions, floaters, headache not relieved by treatment or Tylenol, right upper quadrant or epigastric pain, and hyperreflexia. With hyperreflexia, we're thinking about deep tendon reflexes that are 3+ or 4+, so very brisk. We can also see something called clonus. Clonus is if we hyperflex the foot, and when we let it go, instead of just falling back down to its resting state, it twitches. And it's that excitability of the central nervous system. And so the number of times it twitches before it reaches its resting state is the number of beats of clonus. The more beats of clonus, the more hyperreflexive she is. So any of these, in addition to the high blood pressure, can be diagnostic for preeclampsia. Most often, proteinuria is a big one that we see. And we can measure this either with a 24-hour urine and looking at the protein over a full 24 hours, or with a protein creatinine ratio if that value is greater than 0.3. So if we have a patient who is preeclamptic, we have to think about what our goals are and what we're going to do. The very first thing to think about with preeclampsia is we want to try to prevent a seizure. So preeclampsia, pre is before, eclampsia is if we're having seizure activity. And everything prior to the seizure is preeclampsia. We would like for her not to have a seizure. We also need to manage her high blood pressure. We need to monitor her and her baby, and we need to be prepared to deliver if necessary, depending on the severity of her symptoms. So to prevent the seizure, magnesium sulfate is the main thing that we will use. Magnesium sulfate is given typically IV, but it can also be given IM. And it is central nervous system depressant. So it's going to take the excitability and bring it down, okay? But because it's a central nervous system depressant, we can depress things too much. And so if that happens, this can be dangerous for the mother. So we're monitoring for signs of magnesium toxicity. And we would see absent deep tendon reflexes, urine output less than 30 mLs per hour, respiratory depression, slurred speech, and severe muscle weakness. Any of these symptoms would be concerning. If we are concerned that she is experiencing magnesium toxicity, our antidote is calcium gluconate. Calcium gluconate is going to push the magnesium off of the receptor sites of those cells and very quickly resolve the symptoms that we're seeing. So if your patient has a respiratory rate of 4, we should give calcium gluconate. We should also turn off the magnesium. If she's running on IV, we should shut it off. The other thing that's important to note with magnesium sulfate is that it is going to also have an effect on the uterus. And so it actually acts as a tocolytic, which relaxes the muscle of the uterus. This can make it more difficult to get her in labor and delivered if we're inducing her because of her preeclampsia, but more concerning is it can cause uterine atony. In the postpartum period, it's very important for the uterus to contract and squeeze and tampen out those vessels that we're feeding the placenta. And if that muscle is not contracting well, she has a risk of hemorrhaging. So this increases her risk of postpartum hemorrhage. So this is something we monitor closely for as well. As far as managing her hypertension, magnesium sulfate can have some effect on her blood pressure, but it's not a means of treatment. The medications we typically use to treat the blood pressure include labetalol, Procardia, or also known as nifedipine, and hydralazine. And these medications can be given while she's also on magnesium sulfate in order to bring the blood pressure down to a normal range that's safer for her and for her baby. For monitoring, we're going to be monitoring her symptoms of preeclampsia. We're going to be monitoring for signs of magnesium toxicity. We're going to be monitoring the baby. So continuous fetal monitoring. We may need to do things to help the baby. We might need to reposition the mom and things like that. The thing that we can also see with our baby is we can see the baby have a sedative effect from the magnesium sulfate because it does cross the placenta. So what we might see on our fetal heart tracing might be minimal variability, which can be a sign of a sedated or sleepy baby. We're going to be monitoring her vital signs, watching that blood pressure, and then monitoring her uterus if she's delivered and watching for those signs of bleeding. Women are typically on magnesium sulfate for 24 hours after delivery, so this is something we're watching for in that postpartum period. If her symptoms are severe and she's on magnesium sulfate, we need to be prepared to deliver her. We would prefer for her to be greater than 34 weeks, but it's ultimately going to be whatever is the safest depending on her condition. Greater than 34 weeks, these babies tend to do really well. If we're going to deliver her, we're going to give her betamethasone. Betamethasone is going to help increase the surfactant production for the baby to help the lungs be ready if the baby's born early. And then how we know our interventions are working. She doesn't have a seizure. Blood pressure is improving. Also, diuresis and decreasing edema and improving labs. And so the diuresis and decreasing edema typically will happen after delivery. And so oftentimes with our preeclamptic patient, we said oliguria is a symptom. She might not be putting out a lot of urine, and that is a potential concern because we need our urine output to be greater than 30 mLs per hour. And if it's less than 30 mLs per hour, her body is hanging on to the magnesium more than it should. So instead of metabolizing through it like normal, she could develop toxicity just because she's not excreting it as she should. After the baby's born and when she starts to improve and she starts diuresing, we often see a big change very quickly. So she might be putting out 30, 40, 50 mLs per hour of urine and very suddenly starts putting out 250 or 300 mLs of urine. So we can see that diuresis starting. The edema starts going down, the labs improve. So that is preeclampsia, hypertension. A 40-year-old woman whose 34-week gestation has the following vital sign readings. At 10 o'clock, her blood pressure is 148/94 and her pulse is 88. And at 2:30, her blood pressure is 152/92 and her pulse is 86. What should the nurse assess for next? So we have two readings that are elevated greater than 140/90, and they are more than 4 hours apart. So we should start looking for preeclampsia. So we're going to check for protein in the urine. We're going to check for hyperreflexia or clonus. We're going to check for the central nervous system involvement, also asking about her headache if she has one, or visual disturbances. We're going to ask about right upper quadrant or epigastric pain if there's any liver involvement. And we can do labs and look at her liver function tests and her platelets. And then we're also going to check the baby and do fetal heart tones. Our next scenario is Nadia. Nadia is a 34-year-old who's now 24 weeks into her second pregnancy. Her last pregnancy was 7 years ago. Her BMI is 32.4 and her father has type 2 diabetes. Gestational diabetes was diagnosed during her first pregnancy and her first baby was born at term weighing 30.8 kilos. She's been diagnosed with gestational diabetes during this pregnancy by a 3-hour glucose tolerance test. So if we look at Nadia and we just think about the scenario for a minute first. So she's 24 weeks. She had gestational diabetes with her first baby, so she's definitely at risk of developing that again this time. She also has a BMI that's greater than 30, so she's considered obese, and that also increases her risk as well. She had a glucose tolerance test, and it showed that she has gestational diabetes this time. So when we think about diabetes for Nadia, we're going to be thinking about the fact that she's going to have poor glycemic control. So assessing for signs and symptoms of hypoglycemia and hyperglycemia for her. If she has poor glycemic control throughout her pregnancy, what might that cause? It can cause macrosomia. Macrosomia is a baby that is larger than anticipated for the gestational age. And a baby that grows large has some risks that go with that. One of the main risks that we're concerned about with macrosomia is if the baby is going to fit through the pelvis and be able to deliver vaginally, or if she might need a C-section delivery because that the baby is so big. The baby also has an increased risk of birth injuries during a vaginal birth because an increased risk of things like shoulder dystocia. Babies that are born to diabetic moms also have a higher risk of hypoglycemia. So these are all going to be things we consider for Nadia's macrosomic baby if her baby grows big. So neonatal hypoglycemia is a concern. The other thing that can happen is respiratory distress syndrome in the newborn. This is interesting because if a woman has poor glycemic control through her pregnancy, her body gives the baby a lot of glucose. The baby makes its own insulin. It does not get insulin from the mother, and so the baby's insulin production becomes very high. And if that insulin production is high throughout the pregnancy, that actually affects their surfactant production. So respiratory distress syndrome is something we typically see in preterm babies because of a lack of surfactant. But with a baby that's born to a diabetic mom with poor glycemic control, they also can have a lack of surfactant for that reason. And we can see signs of respiratory distress syndrome for them as well. They also have an increased risk of developing other conditions like preeclampsia, ketoacidosis, infection, and hydramnios or polyhydramnios, where there's a lot of amniotic fluid. Poor glycemic control prior to pregnancy and in the first trimester for patients that are diabetic before they get pregnant also have risks of congenital anomalies and spontaneous abortions as well. Is that a concern for Nadia? Is Nadia's baby at risk of congenital anomalies? The answer to this is no. And the reason for that is because those types of conditions, congenital anomalies, spontaneous abortions, all of those things happen before 20 weeks. Your gestational diabetic doesn't develop diabetes until after 20 weeks, after the organ systems are formed, after all of those things. So Nadia's baby's not at risk of having those conditions, but is still at risk of having the other things we talked about related to poor glycemic control in the second part of her pregnancy. So your patients that are diabetic, whether they are pre-gestational diabetic or gestational diabetic, also have a lower threshold to develop diabetic ketoacidosis than a patient who is not pregnant. Our signs and symptoms of DKA will be the same. So fruity breath, thirst, increased urination, abdominal pain, headache, dry flushed skin, weak rapid pulse, lethargy, and drowsiness are all going to be things we might see. So for Nadia, what kind of things should we do for her? We need to educate her on how to maintain glycemic control. We need to discuss insulin requirements if she needs insulin. And then we also need to monitor her baby. We need to be prepared for difficult delivery in case the baby becomes macrosomic. And then we need to monitor the baby after the baby's born. So types of education for a patient that is diabetic. We're going to teach them how to monitor their glucose. So daily finger sticks, glucose monitoring, this is really important. It is really important for a diabetic patient to maintain strict glycemic control all the time. If they are having these highs and lows and peaks and troughs with their blood sugar during their pregnancy, this is what really drives macrosomia and makes these babies grow larger. And so doing these finger sticks and keeping a close track of what her blood sugars are is going to be really important. Exercise and diet can help her maintain her blood sugars and keep them in that good range as well. And then educate on medications if she needs it to help with her glucose levels. There was a time when we were using medication a lot more than what I'm seeing now. A lot of times your gestational diabetic can be managed with diet and exercise. And if not, they often then are on insulin. But there are some areas that still use medications like, I think, glyburide to manage this as well. For insulin requirements are going to be related to the fact that the further she progresses in her pregnancy, the more and more insulin resistant she will become. And that is true actually for every pregnant woman to an extent, but for your diabetic, this is a bigger concern. So for your patient who is not gestational diabetic, if she is a diabetic before she gets pregnant, she often will see a decrease in her insulin needs in the first trimester. As far as any diabetic, whether they're gestational or pre-gestational, the insulin needs will increase as the pregnancy increases because the insulin resistance increases. So in the second and third trimester, insulin resistance becomes higher and the insulin needs become greater. Your gestational diabetic may not need insulin if they're managed well with diet and exercise. But if they do need insulin, those needs will keep increasing as the pregnancy progresses. Once the baby's born, very quickly the insulin needs to go back to normal for your pre-gestational diabetic. For your gestational diabetic, she will not need insulin after her baby's born. Okay, she will quickly go back to not being diabetic, although it does increase her risk of developing diabetes later in life. For monitoring the baby, we're going to do non-stress tests. So this is where we can put the monitors just on the belly. It's non-invasive, and we can just watch and see and what the tracing looks like. And we're looking for normal baseline. We're looking for moderate variability. We're looking for accelerations and no decelerations. And this is going to give us a good indication of fetal oxygenation. We also can do ultrasounds. Ultrasounds are going to give us an indicator if the baby's growing macrosomic or if we have polyhydramnios and those things, so we can monitor that way. And then we're also going to teach mom to do daily kick counts. And we talked about these teachings also in a previous video about our pregnancy basics as well. So our daily kick counts, if we remember, are going to be monitoring at about the same time each day, and then monitoring for, we want 10 kicks in 1 to 2 hours. So typically picking a time of day each day that the baby tends to be more active, and then just noticing those kicks. A baby that's moving is a well-oxygenated baby. So it is reassuring to us to know that we're getting good kick counts. So that's another way that mom can monitor her baby from home. When it's time to deliver, we need to be prepared for the possibility of a shoulder dystocia. We also need to educate her if she needs to have a cesarean birth based on the size of her baby, if her baby has grown macrosomic. And then after the baby's born, we are monitoring that baby for hypoglycemia. We're monitoring for breathing issues because of the risk of respiratory distress syndrome. And then we're also assessing for birth injuries if the baby had a shoulder dystocia at birth. With a shoulder dystocia, we have an increased risk of having either clavicle fracture or brachial plexus injury. So we're monitoring some of those things as well. Let's now talk about early pregnancy bleeding. So when we think about possible causes for early pregnancy bleeding, we have to first remember that for early pregnancy bleeding, anytime that these women are having early pregnancy bleeding, they've had a positive pregnancy test, they believe that they're pregnant, and they are, like with an ectopic, but there's different outcomes that can happen with this. And so be mindful of the emotional aspect that can happen. So possible causes, one is going to be an ectopic pregnancy. And with an ectopic pregnancy, we have the embryo implanted outside of the uterus. And so typically this happens in the fallopian tube. We can't grow a baby there. So with this, we might give a medication called methotrexate to help stop the growth of the embryo. Sometimes we don't know until it ruptures. And if that happens, then it needs a surgical repair because that can bleed into her belly and it can be concerning. Spontaneous abortion, threatened, inevitable, or complete. So depending on what's happening, if she's bleeding and we still have a heartbeat and a closed cervix, that's a threatened abortion. That one we can try to maintain that pregnancy. If we have an inevitable abortion, we have bleeding, we have an open cervix, and we're delivering. An incomplete abortion happens if we have not all of the products of conception come out and we have an open cervix and bleeding. And then a missed abortion is if the baby passes away and does not come out, and then she needs a D&C in order to take that out. So of these, the threatened abortion is one that we can still try to maintain a pregnancy for. The others are going to be, there's nothing we can do about that. The other thing can be gestational trophoblastic disease or a molar pregnancy. And with this, what can happen is we have the egg that is fertilized is lacking in genetic material and it doesn't grow into a baby. The body thinks it's pregnant, but it's not, there's not a baby, there's not a placenta. So we have high HCG levels, and the cells that are growing are multiplying at a much higher rate than a normal pregnancy would. So the uterus becomes larger faster. We see on ultrasound, we see kind of a snowstorm or grape clusters, and we also have bleeding. So that is going to require sometimes even medications that are also used for quick dividing cells, like for cancer, to stop that growth. Treatment plan for these conditions, one is going to be pain management. If it's a threatened abortion, we'll try to maintain the pregnancy. So if we're close to the age of viability, if we're close to 20 weeks, we might be able to do bed rest and things, limit activity, and try to keep her pregnant if possible to get her to an age of viability. Emotional support. So these women were expecting to have babies and now they're not. So that's a consideration as well. And then we need to monitor their vital signs and monitor bleeding. If we're monitoring vital signs and we're seeing that she's becoming tachycardic, that can be a sign that she's bleeding somewhere, even if we don't see where. If we see she's becoming hypotensive, again, that could be a sign that she's bleeding. So monitoring vital signs is important, and then monitoring bleeding. So let's talk about late pregnancy bleeding. So this is going to be bleeding that typically starts after 20 weeks. We have two main things here that cause it. One is a placental abruption. A placental abruption is a detachment issue. The placenta detaches from the uterine wall. Typically, this is caused by trauma. It can be caused by hypertension. It can be caused by drug use, like cocaine. And then there's a higher prevalence for smokers as well. With this, we have painful dark red bleeding. So it's painful in that her uterus is very firm and rigid. And we can also see, if we put a monitor on this, we can see fetal distress because that we're not getting as much blood flow to the placenta. And so we're not getting as much oxygenation to the baby. So we can see late decelerations as well. With a placenta previa is an attachment issue. And what happens with this is the placenta is attached low and it is attached over the cervix. The typical risk factors for this will be related to previous C-section, multiple pregnancies, and advanced maternal age. This is going to have painless bright red bleeding. So she isn't having any uterine pain or tenderness. She just notices blood in her underwear. Okay, we'll have normal fetal heart tracing with this. And what we need to do for each of these is going to be dependent on the severity. With the placental abruption, this is an acute issue. The placenta is separating. There's nothing that's going to fix that. That's typically going to need to be a delivery. And oftentimes that's an emergency C-section. With a placenta previa, it's going to depend on how much bleeding is happening, where we're at in the pregnancy, and if we can keep her pregnant. And so if she had a bleed and isn't continuing to bleed, that might be monitoring and seeing if we can maintain the pregnancy longer. So it just depends on how much bleeding is happening and if it's an urgent situation. So here's a question. A woman is 28 weeks gestation and had a C-section for both of her previous pregnancies. The woman experiences bright red, painless vaginal bleeding. On her arrival to the hospital, what conditions should be assumed unless ruled out? So this is your placenta previa. Okay, we have painless, bright red bleeding. She's had C-sections before. This is probably a previa where the placenta is covering the cervical opening. How can we determine that that's what's happening here? And also, what should we avoid? An ultrasound is going to help us determine. We can look on an ultrasound and see, where is the placenta? Is it over the cervical os? What should be avoided is vaginal exams. If we put our fingers through the cervix and the placenta is down there, we could poke the cervix with, or poke the placenta with our finger and cause it to bleed more. So we should avoid vaginal exams, but an ultrasound can be used to help us see if the placenta is indeed over the cervix. If we have a patient with a placenta previa, what might we anticipate for her? We'll do an ultrasound to look for the placement of the placenta. We'll put her on bed rest and monitor her bleeding. We're going to monitor the baby, so putting the monitors on and looking at the fetal heart tracing. And we're going to monitor her vital signs. Again, if we see tachycardia or hypotension, that gives us an indicator of loss of volume. Okay. We're monitoring the uterine contractility, so we're looking to see if her uterus is contracting. And then we need to notify our team. So we want anesthesia to know she's there, and we want the NICU team to know as well. If we can keep her pregnant, we will try to do so, but we need them to be aware in case we need to very urgently go for emergency C-section. If a patient has a placenta previa, she will be delivered by C-section. She has to have a cesarean birth because the placenta is in the way. She cannot deliver through the vagina. We'll have a surgical consent signed. We're not going to do vag exams. And then we should type and cross match for blood products, just in case she bleeds a lot. We would like to have 2 large bore IV access. So having 2 IVs is better than 1. If she bleeds a lot, so the thing with this is that it can be fine until it isn't, and then we can have massive amounts of bleeding in a short period of time. So having 2 large bore IVs gives us the possibility not only for fluids, but for blood products as well. And then doing a cesarean delivery if we need to. So our other patient is 32 weeks gestation, and she experiences a sudden onset of intense localized abdominal pain with dark red vaginal bleeding after falling down the stairs. On her arrival at the hospital, her fetal heart tracing shows late decelerations. What condition should be assumed unless it's ruled out? So this patient has a good story for placental abruption. She has painful bleeding. So her belly is painful. She has a rigid abdomen. She has dark red blood. She had trauma. She fell down the stairs. These are all signs. And then the fact that we have late decelerations on our fetal heart tracing is also a possible indicator as well. So remember that with this is a detachment issue where the placenta is detaching from the uterine wall. What route of delivery will we anticipate for her? She's probably going to be an emergency cesarean birth. So our goals and actions, we need to control the bleeding. We need to be prepared to deliver her. We need to be prepared for the hemorrhage, and we need to monitor for signs of hypovolemic shock. So we should very quickly notify our team, anesthesia, NICU, get the surgeon, and we need to type and cross match for blood products for her as well. We need to have our uterotonics ready. So uterotonics are medications that improve uterine tone. So after delivery, we can give those to help the uterus contract. We need to also have 2 large bore IVs, and we need to think about maintaining those stable vital signs. So using IV fluid and blood products to maintain tissue perfusion. So we're oxygenating everything. And then we're monitoring for signs of hypovolemic shock. So our signs of hypovolemic shock include tachycardia and hypotension, also dizziness, lightheadedness, confusion. We can see pallor, oliguria or decreased urine output because she wouldn't be perfusing her kidneys well, and cool, clammy skin. And this patient is at high risk of developing DIC, so we need to monitor for that as well. That concludes high-risk prenatal care. We applied our knowledge to patients with hypertension and preeclampsia, gestational and pregestational diabetes, early pregnancy bleeding, placenta previa, and placental abruption. Keep watching for scenarios that apply our knowledge to labor and birth, postpartum, and newborn care, or go back and meet Abby as we review pregnancy basics. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.